Glad to see so many people joining us this morning. Thank you so much. We have some terrific information and hopefully dialogue to share today. I'd like to start with just some general, well, there is some housekeeping announcements, but more just general information if you're new to the MetaECHO community. I'd like to let you know that these calls are always recorded, and together with the presentation, they are stored in the Project ECHO Resource Library, or Pearl. We'd encourage you, if you don't currently have access to Pearl, to please reach out to our ECHO replication email address to have yourself added. Please request access to the Project ECHO Resource Library. Also, we're always looking for content for these presentations. So if there's something that you would like to share with the community, or if you would like to learn more about something in particular, to please just reach out to myself. My email address is there. Again, I'm Christine Weiss. I'd also like to let you know that the MetaECHO community newsletter is where we share information on these calls, on publications, which we're going to discuss today, and information that is taking place within the ECHO movement. If you do not receive that currently, it's a bi-weekly newsletter. Please go to the main ECHO website at projectecho.unm.edu. At the very bottom of the page, there's a link to enroll in a wide variety of newsletters, and the one I'm referencing would be MetaECHO. I do want to share an important announcement with you all. We have some news to share, and that is regarding the dates of the 2025 MetaECHO conference. We will be getting together about a year from now. More publication and information will come out on this in the next couple of weeks, but you all are the first to officially hear. And if you would, please mark those dates, the 7th through the 11th of 2025 here in Albuquerque. I would also like to just share some of the upcoming community call topics here at the beginning, and then we can just spend the rest of our time diving into the content of today's call. We will get together again at the end of September and have a really neat discussion with Phil Nixon of Children's Health Queensland regarding social network research and cultural brokers. It's a really interesting idea and some terrific research that they are going to share with us. So please join. I think you'll appreciate that. We're looking to schedule the rest of the year, and some of the things that we're looking at are ECHO in education, applying the gender equity lens to your ECHO programs, and then also how others are using AI in their ECHO programs. Encourage you to join, but also if any of those are topics that you would like to contribute to the discussion or the presentation, same thing. Please reach out to me. We'd love to include you in that. All righty. I, together with my colleague, Wesley Kuchela-Webert, are supporting this call today, he from the IT side. And I'd like to, at this time, just kind of brief you on what our presentation is going to be today. With Nick Cuttriss, he will be our speaker today. And it's really around some important research publication information that's coming out. Should be any moment. It's published. We're just waiting for everyone to have open access. And when we talk about research, why this is important to the ECHO movement, I just want to share some perspectives on that. All of our research from all of the hub partners helps add momentum and credibility to what we do at ECHO. So it's an effective intervention that we want to encourage everyone to be participating in. It means that we get more buy-in from our institutions, from our government agencies, from our ministries of health, from our NGOs, and that means we have more opportunities for funding, something we're always searching for. It ultimately also means that we reach more people and are able to impact more lives. So across the ECHO network, new research is pretty staggering. Almost every day we're getting news about new publications. We post those in the MetaECHO newsletter every couple of weeks. So we always make sure we keep tabs on those and celebrate those publications. At last count, we had about 647 peer-reviewed publications, but only about 82 of those represent patient or end beneficiary outcomes. So that's what makes the information you're going to hear today so significant, and why Matt and Nick and the team's research is so significant. So if I may, I'd like to introduce Nick Cuttriss, Dr. Nick Cuttriss. He's also the founding director of the Echo Diabetes Action Network. I am going to put his presentation, a link to it in the chat. So if you'd like to follow along that way, you're welcome to. Nick, if I may, it's all yours.
Great, thanks so much. And I was mentioning earlier, my computer's been acting finicky. So if you see colorful straight lines all of a sudden, just let me know. And as always, this will be interactive. Just feel free to interrupt and ask questions. And if for organizations who are present right now, if you could type in the name of your organization, and if you can put a dash active or non-active with diabetes-related echo programming, so we could do a little poll tally. Many of you are already kind of familiar faces in the Diabetes Collaborative that we meet monthly. Some of you all are new, and so we're trying to promote replication. So Matt Bouchon-Abels, he's in clinic right now. He might be able to hop on towards the end. So most of this data I'm going to share with. The newer data is coming out of New Mexico, which he has spearheaded over the past decade. And so this is an article Christine was referring to. We'll share some data on this and looking at patient level data from New Mexico from the past decade since the endo echo program started in 2014. So why is this article, and also hard work, and as you all know, also enjoyable work with community partners so important and relevant to your programming? Because we have diabetes system failure, and there's an urgent call for us to support underserved communities and the primary care community in addressing this system failure. So if we look back over the past several decades, there have been many new advances in diabetes medications and therapeutic initiatives and diabetes technology. But despite all the new therapeutics, there continues to be therapeutic inertia, and we're not moving the needle when we're looking at glycemic targets for people living with diabetes. And if you look at HEDIS over the 5 years of data, you can see that the majority of people, close to the majority of people living with diabetes, where the A1C targets should be less than 7%, the glycemic kind of targets where many insurers look at is 9%. And over a third of people living with diabetes have A1Cs greater than 9%. And you can see the disparities also amongst Medicaid and commercial. And if you look at one of the biggest burdens, cost, and also just of care of someone living with diabetes and the effect it has on families, of thinking about dialysis and kidney failure and CKD and diabetes, where 3 in 4 people living with diabetes CKD are even aware that they're already in stage 3 or 4 because it's not being detected. And if you look at disparities amongst people who have diabetes and CKD, where Native American populations previously almost doubled the risk and now down to 20% because of targeted efforts by the community, Asian Americans, 20% higher risk, Blacks as well. And so there are reasons for hope that we've seen from the Native communities. When you make a targeted effort, disparities can be addressed. But crossing our fingers and going about the same ways of doing things, we're not going to move the needle. And so what are some barriers to people receiving specialty care and relying on primary care? There's the financial obstacles, there's supply-demand mismatch. I'll show you some slides on. There's people going to not wanting to go the distance. And then even for people who live in urban areas where there are specialists around the corner, there still remains barriers to that. I've got some data to show for urban as well. And this is the map of diabetes pediatric endocrinologists in the US on the left and compared to primary care providers. And so if you were going to try to target the majority of people living with diabetes, we really need to focus and upscale primary care, and the ECHO model has a role to play. And there's a shortage of over 15,000 endocrinologists right now. If someone wants to see me in a university hospital, you're a good 6 months out, and for a new visit, and even for a follow-up if you want to try to reschedule. And so the fact is, the majority of people living with diabetes, even type 1 diabetes, rely on primary care providers to manage their diabetes. And if you look at mortality data in the US, and you look at the disparities between urban and rural, you can also see there's been, not just in substance abuse, but also in diabetes, we're seeing poor outcomes in the rural communities where the gap is more than tripled in the past 2 decades, which goes back to the data I'm going to share with you on New Mexico. And then specific to people with diabetes, people are less likely to participate in diabetes self-management education. They're more likely to go to the emergency room for diabetes-related issues, and they're less likely than urban patients to experience improvements in blood pressure control and cholesterol and things beyond A1C. So this seems like a pretty good match for ECHO, right? Very similar to some of the initial observations that Dr. Arora had with hepatitis C, where there's a lack of specialists, there's a poor outcomes, high disparity, and there's lack of confidence of primary care providers managing complex conditions. So diabetes is really a perfect fit. And when we're talking about diabetes echoes, there's many echoes out there that are calling themselves echoes, where it's really not the heart of the model when you think about diabetes and complexity of care, and kind of how we see the kind of diabetes community with an echo, see diabetes related echoes. It's not an endocrinologist like me getting up and running the show. It's having a multidisciplinary interprofessional team that not just includes an MD like an endocrinologist, but it includes a patient advocate. It requires a community health worker, a social worker, a diabetes educator, a pharmacist, a behavioral health specialist, a primary care provider, on occasion a nephrologist. Sometimes there might be a cardiologist who pops in. So diabetes is complex, and being able to support primary care providers from different perspectives has really been found to be beneficial. And that's some of the data that I'm going to share with you. And typically, everyone runs echoes differently. Some of the best diabetes echo programs that are where spokes are engaged, there tends to be a diabetes kind of champion in the community in that center. And so in that, there's an F2HC lookalike. And it's, in terms of your spoke recruitment, it's really trying to find those diabetes champions, regardless of what level they are. MD nurse, who, if you're looking to get a clinic active, it's finding usually someone living with diabetes or has a spouse or partner with diabetes, has really been successful in getting spokes involved. And so in terms of how does ECHO impact diabetes, there are over a dozen articles out there related to diabetes and ECHO. And if you're running an ECHO program related to diabetes, thinking about diabetes, there's also a link for these I'm going to share with you on the EDAN website. But there's plenty of data out there showing that ECHO makes a difference in patient outcomes. And we're going to look more at improvements in diabetes care for outcomes and glycemic assessment status. And one thing I want to kind of call to attention, this outcome and glycemic assessment status, That's a long word. It used to be called diabetes control, kind of poor control or good control. As I shared with you earlier, there's no such thing as poor control when there's system failure, where the majority of the people living with diabetes can't meet target. And so saying that patients are non-compliant, that's not fair. This is system non-compliance and system failure. And so NCQA recently changed the naming of that, and so it's no longer good control or poor control. And language matters, and that's something in our community, and sharing that back out to the primary care providers. That's really important. Anyways, there's also clinical improvements using ECHO to leverage QI in the clinic, looking at clinician change in knowledge, confidence, etc. And then we also have healthcare outcomes in terms of reduced spending. So let me start first with patient outcomes. And so the EndoECHO program started over a decade ago, and it was funded by the Helmsley Charitable Trust. And it targeted FQHCs throughout the state of New Mexico. New Mexico is one of the most fifth largest country in the U.S. And 30 of 33 counties are designated medically underserved. I've served there as a pediatric endocrinologist, and there aren't more than one hand of people to count in the state like me. So through the opportunity of the Helmsley Charitable Trust, this program was sponsored, and it has been ongoing since, without ongoing funding from the Helmsley Trust. But with that funding, we're able to look at patient-level outcomes, which is, as you all know, very challenging for ECHO programs. And this is just an overview of the data. And so what we did was compared people living with diabetes who were being cared by the diabetes champions in the spoke sites, and compared them to people living with diabetes cared for at University of New Mexico in the specialty clinic. And so the people who were cared for at the spoke sites were a little bit more Hispanic, Latino, and a little bit more underserved in terms of Medicaid breakdown, but similar. And some of the findings that we found were improved patient perception or self-confidence, and with the quality of care. There was patient activation surveys were done. There was improved patient activation regarding self-care behaviors. And then there was also improved prescription-related quality metrics as well. So you can also extrapolate potential health cost savings in that as well. And then in terms of the A1C data, of the ECHO participants, 800 plus compared to the specialty clinic, 150, not only were A1C levels decreased from, quote, before when we were talking about the definitions of glycemic control, controlled versus uncontrolled, the percentage went down dramatically with the ECHO people living with diabetes, where you can see there really wasn't much of a change in the specialty site. And the next slide, I can show you there the change in A1C. And then another thing that related more to type 2 diabetes is changes in BMI as well, were observed and superior in the ECHO sites compared to the specialty sites. And so a drop of an A1C of 1.2% for those of you who aren't in like the diabetes world, that's huge. So usually pharmaceutical companies, like a change in like 0.2 or 0.3%, where they look at over 6 months of time, they'll market new products for that. So 1.2, that is a huge, huge, huge change. And this study, this wasn't over 6 months. This was people who've been engaged in the program for years. And so this is sustainable change. There's other studies out there related to diabetes echo programming where there's been more stuff is going to come out on A1C change, but those are very short time, 6%. And you all who do echo programming know to move the needle, it takes more than 6 months to do programming, and it takes ongoing echoes, recurrent, and supporting these providers. So this is really fantastic data to share. And then aside from the numbers, it's talking to people living with diabetes, and this is a picture on the right is one of the diabetes champions in one of the rural clinics in Albuquerque, who's kind of the local diabetes doctor there, and there's decreased stigma and more openness about talking about diabetes. Clinician change. So this tends to be kind of more bread and butter of echo programs, looking at change in knowledge and confidence. And then in addition to that, kind of general benefits you all can talk about related to diabetes is focus on HEDIS and NCQ outcomes. In terms of recruitment, this tends to be no cost CME. There's an emphasis on quality improvement, and when you're talking to funders or spokes or medical directors to allow their clinicians to participate in echo, it's really giving them an opportunity to do the right thing. From the New Mexico data, confidence increased over 60%, over 110% increase in better equipped to deal with barriers. Referrals went down, once again, kind of cost savings from there. And the champions at the spoke sites, the primary care providers, were receiving increased referral. So word got out too that people locally, where they would usually travel to the university hospital and maybe not show up or not go at all, now instead business was increasing in the clinics, the local clinics. And beyond New Mexico, I mentioned there's additional publications out there regarding urban populations. So, GW and Chicago have a paper out there on that. Type 1 diabetes. I was previously at Stanford in California. We have lots of findings on complex diabetes, of using type 1 diabetes and looking at technology. And then Chicago, DC, Washington State, and New Mexico also have a recent publication that came out on looking at prescribing confidence changes. Clinic improvements in California, we did we used QI as part of our echo. So every quarter we did a QI session. So we had our champions showing up on our weekly programs, and then every quarter invited other QI people from the clinics to join. And instead of being a kind of an expensive QI project, we had the clinics select, one or two or three things that they wanted to focus on. So they picked, we didn't assign it. And then every quarter they would share back out. And of the 31 QI initiatives that were attempted, when we were done a year out, over 80% had completed them or were in process of doing it. And so they could focus on structural process or outcomes. And so if you're working with managed care organizations, there might be also opportunities of thinking about funding from a QI perspective as well. The EDAN funded 3 programs to do a diabetes CKD collaborative, so University of Washington, Chicago, and Rutgers. And DQ&A did a qualitative assessment of providers who are participating in this CKD to kind of get a better understanding of echo and what providers, clinicians thought about echo and the opportunity it would have. And these are just some of the notable quotables that are out there and are available for you all to use for funding and making your pitch for why echo is important and why clinicians feel it's valuable and needed. So those programs now have this collateral to use, and we give you permission to also use this as well. And then last year, Rutgers University, we had a call on this community about a year and a half ago. Some of you might have been on, where we saw some cost-saving data from New Jersey, from Rutgers. So looking at patient panels of champions from the spoke sites who participated in ECHO of Medicaid patients, costs were decreased for people with diabetes compared to controls there. And so, as you all may or may not know, it's the hospital admissions and the ER visits which tend to be the highest cost drivers for diabetes. So if ECHO is making a difference, why aren't there more diabetes-related echoes when diabetes is just increasing and so many people are at risk of prediabetes? So about 3 years ago, I left Stanford, and with Linda Baer, we started the ECHO Diabetes Action Network, and in collaboration with the ECHO Institute, are dedicated to trying to get more organizations to start diabetes related ECHO programming. And our kind of guiding principles, where we'll support programs interested in doing diabetes-related ECHO, around access, around beyond A1C, about increasing confidence to frontline providers, about addressing disparities, about diabetes education. Everyone has the right to it, even though there's a huge gap in it. And systems, once again, moving the needle and using the ECHO movement to do so. And we meet monthly, our ECHO Diabetes Collaborative. We have toolkits where we'll share, provider knowledge, confidence, case submissions, language, templates, etc. So for those of you all who aren't involved, would love to see you there. And we're a national movement, and want to be a global movement. There are some Canada, Ecuador, and Australia have showed up on occasion, and hope more will continue to do so. And I do a lot of global health. I'm speaking more on data in the U.S. But we need to increase this globally as well. And so even though diabetes-related ECHO programming is increasing, compared to all ECHO programming, diabetes is less than 1% of all ECHO programming. And people living with diabetes is 1 in 10 of the US. Prediabetes is increasing. And so if you all are running ECHO-related ECHO programming and trying to target the public health crisis in the US or globally, and receiving public funding or state funding and not focusing on diabetes, or don't have a plan to focus on diabetes, I'd kind of question why not? Ethically, how can we not? And so, do we really need more studies to demonstrate the need for diabetes-related ECHO programming? Research is great, and you all should continue to evaluate ECHO programming. But I hope from what I shared with you all today, waiting for more studies to come out should not be a barrier to start doing diabetes-related programming. If you all read the news today, there's a great article on North Carolina on diabetes, what's on formulary. So one of the more expensive drugs right now, Ozempic or Wegovy for weight management. It used to be covered for health employees for the state, and now they change it to allow it for Medicaid patients because it's the right thing to do. It's needed. And people with the employees now don't, it's not on their formulary, but the people with the greatest needs are now getting it. And so these are just some of the additional articles that I kind of referenced that are out there related to diabetes. So there's a lot. So I'd encourage you, it's time to take action. And once again, morally, how can an organization committed to the principles of Project ECHO not act to confront the disparities that we're facing right now globally with diabetes? So you can take a picture of this barcode, or you can also email linda@echodiabetes.net if you're interested in joining the collaborative. We meet the second Tuesday of the month, and would love to invite you to share what you've tried or are doing with diabetes and have us learn from one another. So I'll stop there because no one interrupted me. But if you want to put in some comments and just some things maybe to think about, is for those of you who've been doing diabetes-related programs, what are some successes? Many programs have done diabetes programs, but then they have to stop because of funding and there's obstacles. And so, hearing and sharing some of that might be nice for this call. And then in terms of sustainability, how can we, as the ECHO Institute and EDAN, help make diabetes-related programming more sustainable when thinking of other ECHO programming? So.
Bravo, Nick. And your prompts there included many different questions. One of the first things that you stated or that you asked people to do was put in where they're from and if they had an active or inactive program. There are a tremendous amount that are inactive. I'm guessing those are ones that had the program, was doing diabetes before and now isn't. I'd love to hear from some of you all. And let's say the reason you stopped was not funding. That may take out a bunch of you, but why did your program stop? Please just chime in.
So Amy Fisher from Rutgers, with once again the great the study I showed you on cost, even with the cost savings, they lost funding for that. And I know Jay, you might be on West Virginia. I can maybe speak for him. We had a recent conversation where there just wasn't enough endocrinologists, specialists, diabetes. There was so much turnover in faculty, couldn't have a core group. That got us thinking, maybe could we do a kind of a core group that might be able to help programs in different parts of the country. Anyone else, any other reasons? Or anyone maybe want to comment like dynamics that might be different with the diabetes related kind of endo groups versus your other ECHOs that might be more sustainable? And we have a comment from Penn State. Like others, Penn State's issue has only been funding and hub expertise, or are unable to commit to host an ECHO. Certainly not lack of interest within our ECHO hub or recognizing the importance. And then from Gray, we have in HIV, ID, echo, and diabetes may be a topic for a day, otherwise not an ongoing topic.
And Ann Lacey has a question for us. Can you discuss the ADA-GP Alliance and if that might help grow EndoEchoes or EDAN?
Yeah, so the ADA, the American Diabetes Association, has different interest groups, and so there's been one in primary care for quite some time, and now there's kind of a more formalization of that primary care initiative that is getting ready to kind of roll out, and that is a potential for collaboration, and that's something that hopefully we can kind of continue to foster, but it's very early in its infancy right now. But regardless of that, ADA they do have a separate track and interest group for primary care, and so that's another, in terms of spoke recruitment. It doesn't seem like that's the main issue or barrier for many of you all. It seems it's more of kind of internal kind of hub faculty and funding. But who knows, maybe some of those folks who are primary care providers who are champions and they really care, that you can find ways to partner with them and have them support you all in terms of funding and outreach, or they can even be on your hub team. So we did that in California, in Nebraska, Iowa, South Dakota, ECHO, the kind of, while University of Nebraska supports, it's one of the FQHC spoke sites is kind of the main hub. And so kind of trying to be creative for your state or your community where you're doing your ECHO, there's different ways to think about it as well.
Thank you. But other questions for Nick on the outcomes? Is there any questions there? Hey, Carmela. Program getting ready.
Oh, and then, yeah, and then University of Nevada, call out to them. That was the first endocrinology echo that we're aware of in the U.S. that started before New Mexico. So very great that it's back up and going.
How about questions for how Nick can help you? Is there anything that maybe he offered a lot of different kinds of support for you that have inactive programs, or anybody that's it's on the board for 2025?
I guess what are people's thoughts for those of you where there's barriers to hub faculty of ongoing support, and if you had your internal like administration running the ECHO, and maybe you had someone locally kind of hub team who's a patient advocate, a clinical social worker, someone who kind of is more familiar with the local kind of social determinants of health, but you had other hub team faculty members, the endocrinologist, the nephrologist, the pharmacist, the educator who might not be locally from your state. Do you think that type of service support would be beneficial or decrease barriers to doing an ECHO if we were to offer hub faculty to run an ECHO? A quiet group this morning.
Yes, I think it would be very beneficial, even to the ones with active programs, because we struggle, I know, with keeping hub team members or subject matter experts able to engage as well. And I was going to say, I'm not the coordinator for this one. We have a school nurses and diabetes care program at Oklahoma State, and that's been a really good way because our audience base is school nurses and diabetes care volunteers through schools. And so we have a pediatric hospitalist, we have a clinical pharmacist, we have, you know, an endocrinologist, we have this team, but it's, we have a really specific set. And so it's, I don't know if you're looking to like dip your toe in that, it's been really beneficial. And those people just want to learn, and they are bringing cases, they see it every day and they deal with it and they want to learn. So it's awesome.
And there's another, that's great. Then I don't know if you've connected with the DISH program as well, diabetes and school health from one in Washington and one in Missouri as well, where those have also been really successful and high interest programs. Abby's got a question.
Hi, everybody. So thank you so much. This presentation was really wonderful, and I am so impressed with your outcomes. So kudos to you and the team for that, for sure. I just wanted to mention a couple of things. Obviously, our issue at Penn State is always funding, not just, we certainly have endocrinologists who could support this, but we found that having a local hub team is really important, as well as funding to support our staff time for running the ECHO series. So I know that that's the most obvious issue, but I just wanted to flag that. So if there is funding or staffing or hub expertise support, that would be incredibly helpful. I did also want to mention, though, that we have incorporated, so I think someone else mentioned, we have a couple of series that are geared towards primary care in general, and so it encompasses a large number of topics that may face that rural primary care clinicians may face, and we've included diabetes as a topic in those. So it's not like we don't have a specific diabetes focus, but it's just included among many other topics. So I don't know if that's helpful or not, just as a creative idea to incorporate this work, but also, if you all are offering funding and staff, that would be wonderful as well.
Yeah, well, hopefully we'll have more. We did a recent collaborative around CKD and diabetes, where there with those three groups, with Colorado, Rutgers, and University of Washington, where there's seed funding to like co-sponsorship, like around $100,000 for 6 months, or 75 to 100 for 6 months. Programming, and so really trying to get more of that and make it easier for you all to do that. And as you mentioned, it's just kind of, you know, how can you kind of leverage your other echoes that you're doing and maybe put diabetes in there. I know Champagne, you know, had a conversation, you know, last night doing similar stuff, where incorporating kind of the diabetes into another topic. But there's, you know, that from the CKD diabetes experience, when you mix the two together, the feedback we got from the spoke sites in the 3 different states was just huge interest, more so than other programs where there's just I mean, it's just so common. It takes up, you know, clinicians panels, so it's practical to them.
Nick, I've got another question. This is probably for the audience as well. Has anyone looked into whether ARPA-H, ARPA-H, has a program to scale rural diabetes care? This may be a potential area of support. Has anybody looked into that? Nick, what are your thoughts?
I have not heard of a ECHO. I haven't gotten any feedback of knowing that an ECHO program's been doing that for diabetes yet. I think it's important. You know, look, I'm a pediatric endocrinologist, but even if you look at type 1 diabetes, where the majority might get diagnosed in childhood, the majority living with diabetes are adults. And the burden is there. And as we, you know, age, and you look at the baby boomers right now, that's the highest. That's going to be the the highest need and costs. And so, yes.
Shanpin, do you want to address the challenge of de-identified cases and that struggle for you?
Well, can you hear me okay?
Yes, now we can hear you. Yes, please.
Okay, I think that we need to do a study to see, whether the efficacy of the attendee initiated challenging cases, um, the session with those versus the presenter included the identified cases, whether these two type of echo section are providing similar impact to the learning, and the benefit may or may not reach patient care. So so this is what we did. For some session of our echo, we actually have clinician initiated the identified cases in the discussion, but I would say the majority of our sessions, we ask the presenter to include cases and to clearly state the focus of the discussion, and also inviting clarifying questions, and have the attendees and the panelists provide recommendations. But this really is a major challenges. Anyway, that's all.
Yeah, I hear that. And I guess, related to diabetes, one of the best kind of practices that we share on the collaborative that's been successful for getting case presentations is having a member of the hub team, usually a clinician, reach out personally to one of the spoke sites, asking them to do it, and even assigning participants cases to present at the beginning. And so you assign it. It's an expectation, and you'll find out that it's a pretty efficient way to do it. And then on the cases, we also use a general template of the case presentation, bringing it back to the big picture of diabetes and disparities. And so we try to keep we recommend keeping things more focused on the big picture and not getting lost in the zebras of the rare stuff. Because once again, if you look at diabetes and outcomes, we got to focus on the big picture. And so we have those kind of templates as well that are available that from a learning perspective can be helpful.
Yeah, I agree, because one of our hub member, an endocrinologist, he was able to ask the interns of the pharmacist program and also the resident to help present cases, but it has not been consistent. Maybe we have to think about some kind of scheduling strategy to have all the spots open and invite them to fill it in. But yeah, thank you.
And pharmacists, I love you mentioned that. That's also a very emerging and underappreciated target for echo programming, both for hub and spoke, where we're thinking about how care is delivered for people living with diabetes. Oh, and then Gray just put a comment in. Yes, we have a list of individuals in the clinic that are not HIV virally suppressed, and I reach out to the providers asking them to present. Thus far, the echo community has always said yes. So that personal ask versus that email, general email, please submit begging, goes pretty far. And it could be just like, on your echo program in the chat box, just your hub team can send a private message. That usually tends to do it. Oh, that's Marcia, where do you mind saying where you're from? She's asking if there's any echoes looking into gestational diabetes.
Yes, yeah, I am from Texas State University. I'm with the Translational Health Research Center, and we have been looking into
Marcia,
Marcia, I think you're
Uh-oh.
there you
Look
go.
at this.
That's
now
better.
Okay, my
yeah,
bad.
start over.
I'll do it.
Please
I'll
start
do a
again.
super fast version of what I was trying to say. Okay, I am from Texas State University. I'm with the Translational Health Research Center. Previously, we had worked with, it wasn't an ECHO, but we'd worked with some initiatives around maternal health and focusing on the fourth and providing low cost to mothers through an app. What we did right now is that we have a faculty member who's very interested in diabetes. Her research has been on type 1 diabetes. She's wanting to expand it to type 2 diabetes, but we still want to also look at maternal health. And so we've kind of met with her to talk about looking into gestational diabetes. So my question is, are there any echoes out there that have been devoted to that, or have there been any conversations within the echo that talks about gestational diabetes? I've sat on several webinars that bring it in kind of as a backdrop, but I was really curious about that and how that's been addressed, or if it's been addressed.
Yeah, no, definitely shoot me an email. I'd love to connect on this. As I'm aware, no, it's the same thing. It's always kind of in the backdrop. But also now CGM, continuous glucose monitors, are being approved in pregnancy, and there's also potential funding from managed care groups to try that out, and also from industry. So I recently had I'm blanking which state was interested. I think it might have been Michigan, but I don't remember which one. But we should talk. But that would be it's of ongoing importance now, especially with CGM being prescribed and primary care providers needing to be taught how to interpret CGM and
definitely,
or OBs, GYNs or whoever you're saying.
Thank you so much. I appreciate that.
Yeah. Oh, and then here, OSU have the maternal health echo, which we include gestational diabetes talks, and we also include talks on our primary care diabetes. So that would be wonderful.
What else, team? We've got an expert here. Been involved in this for many years. How can he help you? What questions?
And once again, I think with echo, with diabetes related echo programming, doing a block on gestational diabetes, doing the block on CKD, bringing in other topics in primary care, that's really what we're trying to make it easier for you all to do and think is a kind of a sustainable, is a potential sustainable way. So you've got a block on, CGM use, you've got a block on some of the newer, medications, and things can kind of tend to recycle, but those are things that clinicians need to kind of continue to be updated on. There are, programs in New Mexico has been very successful where just kind of people just kind of continue to stay on decades later. Versus some of your other programs, you might do kind of different semester blocks. But even in New Mexico, even though it's an ongoing continuous echo, there's still kind of blocks of different topics that go on throughout the program. And so from like a marketing perspective to your clinicians and even to your hub faculty, they're kind of breaking down diabetes a bit more. And I didn't mention behavioral health, but obviously that's a huge one.
Nick, if you'd like to put your email address there in the chat. I wanted to ask about your toolkit that you mentioned that EDAN has. Does that have like presentation information that somebody could include a diabetes section, a gestational diabetes, et cetera, in their primary care? Is that a resource that's available?
Yeah, so we have a like a PDF version of a replication guide that's been updated And it's more on CKD, but it's the CKD is just a small subcomponent, but it's more around setting up diabetes. And ECHO Colorado is actually in the process of making a little bit more interactive replication guide. So we hope that version will be done in time for World Diabetes Day in November, and we will make that also available. But in the meantime, if you want the just old school PDF version, we've got that.
Wonderful, thank you. All right, we're about to wrap up. Is there anything? Let's see, typo in your email, Nick. Let's see.
Oh, thanks.
Let's stay on for the next 3 minutes and make sure we get the right email for Nick, and everybody copies it so we have it. Nick is very active in the ECHO movement, the MetaECHO community. If you recall this conversation here in a couple of weeks and need some help, just reach out to the ECHO Institute. We'd be happy to put you in contact with him. As a reminder, the presentation is in the Project ECHO resource library. I put the link there. That does also have his contact information. Any last questions or thoughts before we wrap up prior to the U.S. Labor Day weekend? Okay.
Thank you.
Well, thank you definitely to all of you for attending. Thank you, Nick. I know you had a late night on the East Coast last night, and to be here with us today, greatly appreciate it. All of your work, the research, this is just building on all the success for all of us at Project ECHO and the ECHO movement. So I thank you all for all that you do for ECHO, and have a wonderful weekend. We'll see you at the end of September.